Hi, I'm Rick Boddy. I'm a professor of RCEM, and I've been talking about the things nobody told you about troponin at the conference. So this was quite a hard talk to give because emergency physicians are already experts in troponin. Nobody uses this biomarker as much as an emergency physician. We decide who to request troponin in, we know how to interpret the results, we know how to diagnose an acute myocardial infarction. I think we know all about high sensitivity troponin assays by now, and I'm sure we know that NICE recommends that with high sensitivity troponin, a test when you arrive in the emergency department and another one 3 hours later will rule out an acute MI if the levels are below the normal cutoff, which is the 99th percentile. Also, if you use a contemporary troponin assay, so it's not one of the two high sensitivity assays that are out there, we know that NICE currently still recommends that you can rule out 10 to 12 hours after the patient's symptoms began. But what don't you know? Well, you probably don't know all of the evidence behind those recommendations and the reasons why NICE, for example, suggested that we can do the 3-hour rule-out. You probably don't know that there's only one big study that looked at the 3-hour rule-out with high sensitivity troponin I, and it showed that the sensitivity for an acute MI is 98.2%. So you miss 1.8% of acute MIs. You probably didn't know that. When it comes to high sensitivity troponin T, you probably don't know the evidence either. And that's because there isn't very much evidence for high sensitivity troponin T. In fact, in the NICE systematic review, there was only one study cited, and it was published as an abstract in Circulation using just 288 patients. And the sensitivity of that 3-hour strategy was 95%. You miss 5% of acute MIs. So why did NICE recommend it? The reason NICE recommended it is that it's cost effective. We're burning money by admitting lots of these patients for rule-out strategies. It costs a lot of money when most of the patients that we're testing actually don't have an acute MI in the first place. So we really do need early rule-out strategies, and we could probably do better than the 3-hour rule-out strategy. And there are some out there. You could do it with a single test on arrival, and you could get better sensitivity. So I was talking about the single test strategy using a very unconventional cutoff with high sensitivity troponin. If you set the cutoff really low down at the limit of detection of the troponin assay, one single test is enough to rule out an acute MI when patients first arrive, providing that their ECG is also normal. And I cited several big studies, including a multi-centre international study that has been presented as an abstract and will soon be out in the journals, which show a fantastic diagnostic accuracy. And the European Society of Cardiology is even taken to recommending this strategy. Do you have to wait 3 hours then after that to rule out, or even longer? Well, potentially not. You may not know that there's now a 1-hour rule-out strategy. There's an algorithm that would allow us to rule in and rule out acute MI using troponin tests on arrival and an hour later if you use that high sensitivity assay. The negative predictive value of that strategy is 99.1%, so that's pretty good. The only caveat is that the sensitivity is a bit lower, 96% or 97%. That may not be acceptable to all clinicians. So what's the take-home message from all of this? Well, the take-home message that there's reason for caution about some of the rule-out strategies that we use. There are certain things that we do that aren't backed by evidence, ruling out 6 hours after symptom onset, using point-of-care tests in the emergency department. There's no evidence that they can safely rule out an acute MI. The 3-hour rule-out strategy has some evidence, but you might be surprised how thin that evidence is. And you might be surprised to learn that NICE really recommended it because of the cost effectiveness of that strategy. But the final message is that we might be able to do better with an even simpler, even quicker strategy, a single test on arrival to rule out in patients who've got undetectable troponin with a high sensitivity assay and a normal ECG.